So we've talked about keratoconus, what it is, and we know it's naturally occurring and has all kinds of visual compromises, and it's about 1 in 2,000. So it's not uncommon, but it's more common than you would think. Dr. Wade talked a little bit about the ultrastructure of the cornea and the stroma and how it affects the stroma, so I won't get into that. So this is a clinical picture of someone with sort of end-stage keratoconus who was not a candidate for cross-linking, but you can see the cornea is scarred and it's hard to see, but there's some irregular light reflections here. But when you look at this patient on side, you can sort of appreciate how much of a cone that actually is. And this patient actually went forward with a corneal transplant, and Dr. Farid, who's here, who's the head of our cornea and cataract division here at UCI, will be speaking about that next. So keratoconus, our treatments include, stopping eye rubbing, decreasing risk factors, trying to improve the vision with spectacles, contact lenses, corneal transplantation. But currently, none of these treatments really affect the natural course of keratoconus. And what we're looking for is something to stop the progression of keratoconus, and so that we don't get to some of these other treatments. We'd love not to have to do corneal transplants. We'd love for Dr. Blaze and Dr. Che to be able to put a regular contact lens on and for you guys to get good vision without all the visual compromises that you have to deal with on a daily basis. Unfortunately, that will then cause this new company we decided to make right now go out of business with the thing going up for the glare, but I think that'll be okay. Okay, so crosslinking. So crosslinking has been widely available in Europe for many, many years. And I had the opportunity to go to a crosslinking meeting last year in Dublin, and Kathy was there, and it was a great meeting, and we got to hear about all kinds of innovations in crosslinking that, unfortunately, because of our FDA in the United States and other regulatory factors, we have yet to see here. But there are many centers in the United States that are doing crosslinking under study protocols. But the first, it was introduced in '97, so almost 20 years ago now, by Theo Seiler and colleagues in Germany. And so you'll hear people, when they talk about crosslinking, talk about the Dresden Protocol, and that refers to sort of where the inception was. And if you look down at this image here, you can sort of see this is a very striking image showing a regular keratoconic cornea which has no rigidity to it, and then a keratoconus, a cornea that's been cross-linked, and it shows some rigidity to it even just with its own weight. But basically it's a non-enzymatic glycation which can occur with age that Dr. Wade alluded to with an aldehyde reaction, and then you irradiate the cornea and use the riboflavin as a photosensitizer. So very complex stuff, and actually the mechanisms of it are being worked out, and people are looking at different ways of cross-linking the cornea, so it doesn't always have to be with just riboflavin. And this was a schematic showing sort of what Dr. Wade alluded to, that a non-cross-linked cornea has fewer bonds in between the collagen fibrils, and a cross-linked cornea has more. And so the thought is that patients with keratoconus have less of these bridging fibers, and that's why. And the other thing about it is the cornea is not uniform, and so the anterior cornea is different than the posterior cornea. And one of our researchers here, Jamie Jester, has shown that there's a difference in the stability between the anterior and posterior cornea. And that's why some crossing protocols work and certain other ones don't. So again, we talked about the Dresden protocol. This is where you soak the cornea for about 30 minutes, and then you soak the cornea for 30 minutes with riboflavin. First, you remove the corneal epithelium, allow the riboflavin to soak through the cornea, and then you treat the cornea with a low amount of UVA light for about 30 minutes. And it's been shown to be effective, and it shows that you can really stop the progression of keratoconus. Now, this is not uniform. Every surgery that we do, every protocol that we have, every patient is different. So, but on the whole, it's been found to be very favorable in stopping the progression of keratoconus, and also in actually stiffening the cornea, so you get a little bit of reduction in the steepness of your cornea as well. And no serious adverse events were noted. There are complications that can arise, but in this study that was published, again, a small study, but still very safe and effective. This was a study from Avedro, which showed that Avedro is the company that is sponsoring is sponsoring our keratoconus trial here at the U.S. In the U.S. So they have definite financial interest in this. We at Gavin Herbert IS do not. We're just one of their study sites, but our trial is free to the patient because it is sponsored by Avedro. But in their initial trial, they showed that from baseline at 12 months, the patients who were the control patients showed a progression in their indices, and the patients who got treated actually showed a reversal of that trend. So there was a difference of 2.6 diopters of astigmatism, and that's a lot of astigmatism to correct and to stabilize. Again, looking at the data, again, you're showing here that the difference over month 3 to month 6, you get this exponential increase in the stability of the cornea in the patients who were treated. So their cross-linking protocol or treatment, it's actually pretty mobile. It's the nice thing about cross-linking is it doesn't require an operating room. It can be done in the office. It is generally pretty easy for the patient to tolerate, but there are certain requirements that have to be met. And this is just a schematic of their thing. And for people who play video games, this should look very familiar if you have a Nintendo at home. It actually is a Wii controller, and they bought an excess of these from wherever they were made and repurposed it to be used for their unit. So our trial, there's multiple arms to the trial. We were one of the sites, and we've completed enrollment for the KXL001 part of the trial, and this was a multi-center phase 3 placebo-controlled trial. Placebo-controlled means that if once you come in and you're selected to be a participant in the trial, you'll get randomized into either getting cross-linking or not. And so that is one of the considerations when you look for a trial. Is it placebo-controlled or not? Now, there are benefits to being a placebo-controlled trial. There's no charge to the patient for the most part, and there is a crossover protocol, which I'll get into a little bit. It is epithelium off. Epithelium off, did that just go out? Epithelium off is more painful, okay? But there's a lot of data to suggest that it's more effective. And so I'll talk a little bit about epithelium on versus epithelium off protocols in a few. But basically, instead of soaking for 30 minutes, it's soaking for 20 minutes and irradiated at a higher amount of energy for a shorter amount of time. So you're delivering actually more energy to the cornea, but in a shorter amount of time. And the purpose of the study was, can we make this treatment as effective but more efficient for multiple reasons? To have the eye open for over an hour, have the patient sit there can be hard. From a clinician standpoint, that can take a lot of time, a lot of effort. And so if we can make this faster and more effective, then can we mimic the results that were achieved by Dr. Seiler in the Dresden protocol? So I talked a little bit about the steps of the procedure. Step 1 is removing the epithelium. The epithelium, again, is sort of the skin of the cornea, and it's the cornea has the highest concentration of nerves in the body. So if anyone, many of you are contact lens wearers, if you get a corneal abrasion, it really hurts. And so when we do this procedure, it hurts. I mean, it's not the most comfortable thing, but luckily the epithelium heals very quickly. Step 2 is soaking the cornea with riboflavin. You want to make sure you get a uniform soak and a deep soak. And then step 3 is the UVA light, and then with also some more riboflavin in certain protocols. After the procedure, we put on a contact lens, a bandage contact lens. This contact lens is not meant to restore any kind of vision, but just sort of act like a Band-Aid and help the epithelium healing more quickly. You're on antibiotic drops, anti-inflammatory drops, and very, very important, lubricant drops. Good. Okay, so our study, the KXL001, as of March 10th, last week, I looked back and see how many patients we enrolled. We enrolled 42 patients. 11 of them were female, 31 males. 6 were minors, so under the age of 18. 21 placebo, 21 treatment. So a very even randomization, and out of the placebo, we've already crossed over 15 patients and 6 are pending. So, like I mentioned, in this trial, if you get the placebo treatment, the FDA allowed the company to offer a crossover protocol. So, if you got placebo, after 6 months of being in the placebo arm, if you wanted to, you could cross over and get the treatment done, which is sort of unique. So I'm going to show you a case of a student who I treated here, 25-year-old student, progressive decreased vision, second keratoconus. He had crosslinking in his right eye in February of 2013. Some of this is sort of what we look at. This is his keratometry. He had about 3.5 diopters of astigmatism. His average keratometry was 47, so not horrible, but bad enough that his uncorrected vision was 20/125, and the best we could get him was 20/25 with a pair of glasses. Not bad, but he was noticing this decrease. And if you look at, we have all types of fancy equipment that we use for keratoconus. Topography is one, but I think more powerful than the topography is something called tomography, which looks at not only the front part of the cornea, but the back side of the cornea. And so if you look at, these are all different maps of the same cornea, and this shows the front part of the cornea, and you can see this asymmetry that Matt was talking about, asymmetric astigmatism, and you can see this hourglass here, it's just bigger on the bottom, smaller on the top, and this is asymmetric astigmatism. But if you take this on itself, that's very indicative of keratoconus. But really what makes this more powerful for us as clinicians is looking at this in combination with thickness map, which shows that there's thinning of the cornea here in the center. And part of that thinning has to do with the fact that the back part of the cornea is bulging forward. So a lot of times we have a hard time diagnosing keratoconus because in most offices what they have is topography. And the topography only shows you the front part of the cornea. The tomography shows you the whole thickness map of the cornea, and more importantly the back side of the cornea. So if you can see this sort of bulging in the back early, that may tip you off that this may be keratoconus. So this was him pre-treatment. Post-treatment, if you look, so this is pre-treatment, post-treatment, there's a blunting of the difference between the top and the bottom. The back bulging still stays there, and his average keratometry stayed the same, but the astigmatism went down by, what was he before? 3.5 to 2.0, so 1.5 diopters. So that's a pretty big difference. And when we looked at him post-op month 7, he'd mentioned that the astigmatism went down by a diopter and a half. His average astigmatism, or his average keratometry, stayed the same. But his uncorrected vision went from 125 to 2100, but now his corrected vision was 20/20. So he improved, he got what we think is stable, but he also improved his vision. That's because his cornea became a little bit more regularly shaped. The other trial that we had started initially and then was actually halted by Avedro was looking at cross-linking and a different way to deliver the light. There's a lot of research being done in cross-linking these days, and one of them is what's the best way to actually do the protocol. And as part of the biomechanics of it and part of the kinetics of it, you look at oxygen and oxygen saturation, and there's some thought that if you can pulse the light on and off, you can actually get a stronger, more effective cross-linking reaction that has to do with oxygen radicals and a lot of basic science. But nonetheless, they have another protocol which we'd started and stopped, like I mentioned, where you pulse the light on and off. Everything else stayed the same in the protocol except that the light went on and off. And because of that, in their initial studies, they found that this caused a stronger cross-linking reaction and therefore a stronger, more rigid cornea. And if you look at this same sort of image again, no dose control cornea, standard crossing, and then with the pulse, you get even a stronger reaction. Some of this has to be taken with a grain of salt because these are different corneas. They have different biomechanics to begin with, but you sort of get the sense that maybe this might be beneficial. And we hope to open that trial again. So when you look at any study, you have to look at entry criteria and exit criteria. There's certain things that you can't just cross-link everyone. There are certain safety parameters, there are certain patient factors and whatnot. So if you look at this trial that hopefully should restart, it's again placebo-controlled, and really the only difference is If you're going to get the treatment, it's not blinded to the patient. So this is not a blind. You know that you're getting it or you're not. Okay. Part of the reason you know you're getting it or not is if your cornea has been scraped, you got it. If his cornea is not scraped, you didn't get it. So if you're in pain, you got it. If you're not in pain, you didn't get it. Which was really nice that you didn't have to scrape corneas that didn't need it. But nonetheless. Epithelial removal versus not epithelial removal, you get the same soak time with either riboflavin or not, and then irradiated, pulsed on and off for 8 minutes, or irradiated without the riboflavin to see what the differences are. And so, the entry criteria, this is really where most people want to know what's going on. You have to be 12 years of age or older, be able to sign consents, be able to follow the instructions. You can't be pregnant. You have to have signs of progressive keratoconus. So we get a lot of patients who come in who are in their 50s and 60s who are chronic contact lens wearers, stable keratoconic patients, and they come in, well, should I be cross-linked? And my thought is, well, if you're stable, then don't do it, because there is risk with every procedure. And as Matt mentioned, there is the known entity that you will naturally cross-link with age. There's a natural hardening of your cornea, not only in keratoconics, but in normal patients as well. So for this study, you have to be progressive and having a change over the last 36 months. We have different sort of buckets of the keratoconics that we look at as part of the inclusion criteria, and you have to have vision that's worse than 20/20. So if your vision is 20/20 in your contacts or glasses, you're not a candidate for this current trial. And you can't be a contact lens wearer for the last 7 days. You have to be out of the contact lenses to see, because contact lenses can reshape your cornea. And so some of the indices may be off. If you're looking at, if you measure a patient, they come in, pop out their contacts, you measure them, their vision will certainly be different than if they're in their contacts or out of their contacts. And if you've had previous corneal surgery with Intacs or any other previous corneal surgery, LASIK, you're not a candidate. And you have to have a certain amount of corneal thickness. I was talking to a family about their son, and they said that his cornea was too thin, and it has to do with the safety parameters for cross-linking and the fact that UV radiation can cause issues potentially, and so we want the cornea to be a little thicker. Now, there is some debate on that, and so a lot of this still is to be hashed out. And you can't have any previous infections or significant scarring that may affect the treatment. Also, we get some patients who come in whose eyes are sort of dancing a little bit. It's called nystagmus. You need to be able to focus on the light, which is very important for us to deliver the treatment effectively. Vitamin C can affect the cross-linking procedure, and so you can't have taken vitamin C supplements within 1 week of the treatment, and you can't have had like juice or anything the day of or the day before. I had a patient walk in for a cross-linking treatment with a Jamba Juice in his hand, and I'm all, do you have any vitamin C? Nope. I'm all, come on, guy, it's right there. So we had to delay his treatment, but that is part of it. And so I think when you enter into a trial, you really have to be honest with yourself and with the doctor and the protocol that you don't jeopardize your own treatment, but also the science behind it. Because part of a trial is certainly to help the patient, but it's also to help other patients and determine whether or not this treatment is safe and effective, so that we can then allow people to get it without having to go through the placebo aspect of it. So complications. So every treatment has some kind of complication, and haze is one of the most common things we see in cross-linking. Now, this can either be considered a complication or the fact that it's actually working. In my mind, it's probably a little of both. In most patients that we've seen who've had effective cross-linking, they do get transient haze in their cornea. And I'll re-emphasize the word transient. Usually that haze you'll start to see it after a few months, and it'll start to fade by 6 to 8 months after the treatment. And that's very common. And to me, that's a sign that there actually was a reaction in the stroma, and that you are getting some of these bonds being made. In the study in the Journal of Cataract and Refractive Surgery, they show that 8.6% did affect your vision permanently. In our trial, we haven't seen any significant haze that caused a decrease in vision, but certainly we haven't looked at it in a paper fashion. Sterile infiltrates. Dr. Che talked about sterile infiltrates from contact lenses. We see sterile infiltrates from all types of treatment, and you certainly can see it in this. Infection has been reported, so because you're making a big scratch on the eye, that does open the cornea up to infection, and then you can also get irreversible corneal edema. Haven't seen this one yet, but it is reported. So we talked about this as being an epithelium-off treatment for the most part, and there's a lot of debate within the cornea world whether epithelium-off or epithelium-on is better. Certainly epithelium-on is going to be more tolerant to the patient. It's sort of like LASIK versus PRK. LASIK is when you make a flap, you put that back down. PRK is when you just treat the surface, and PRK is more painful. But what we're really looking for is the effect. And so if we can get the same effect with a better safety profile and less discomfort for the patient, that's good for everyone. So the question is, can riboflavin be absorbed through an intact epithelium? And there's some data to suggest that it's not. And so the advantages of epithelium off is that I guess this should be epithelium on, is that you don't have epithelial defects, no need for a contact lens, less complications, less pain. And so the way that people are doing that is to sort of alter the bonds in the epithelium, either with a chemical or with changes in the riboflavin, or with even mechanical. Some people are taking like a little, those things they use to, when they make a pizza, they sort of have those little things to make the dough a little airy. They have like a little scraper for the cornea too, and it makes little micro perforations in the cornea that heal up very quickly, but allow the riboflavin to soak through. So there are different ways to do that. You can alter the way the riboflavin's absorbed into the cornea by something called iontophoresis, which uses a electrical current to change the bonds in between these epithelial cells. And so there's different people looking at this, and we learned a lot about that in Dublin last year. And so really, the goal is to determine the safest, most effective way to perform crosslinking. I'm a big believer that crosslinking is really the way of the future for keratoconus, and if we can catch kids in their late teens, early 20s, and stop them, we will not have as many challenges treating keratoconic patients. So patient considerations, if you get into a trial that's sponsored by a company, it's free to the patient. In our particular trial, it is the fellow eye can be treated. So most patients with keratoconus have it in both eyes. So we're talking about one eye for the trial. The second eye, just so you get the placebo in your right eye. The second eye, if it meets the criteria, can be treated that same day for the crossing. So you're going to get both eyes done with the treatment protocol that's sponsored by Avedro. And then again, the study eye can cross over at 6 months. And if treated, it just say, you come in and, okay, we're going to treat your right eye, and you get into the study protocol. Your other eye can be treated after 3 months. So it's really, a nice way to get both eyes treated without any significant out-of-pocket costs. That being said, the trial is closed right now, so hopefully they will open up again to their next wave. And if not, it could mean that it gets FDA approved, and then they don't have to do this. So conclusions about crosslinking: it is safe, it is effective. Can we get more crosslinking altering the way we're doing it? I think we can, and I think there's going to be a lot of work being done in this. I think our current sort of protocol for crosslinking is very early, and I think that there's going to be, with every treatment we have, there's going to be innovations to make it better, more effective, safer. And so it promises to be one of the first FDA-approved commercially available medical treatments for keratoconus. We've talked about ways to sort of deal with keratoconus, but not actually treat keratoconus. And Dr. Fried's going to talk more about surgical options. So a very exciting thing for all of us should be the fact that on February 24th, there was a panel who supported Avedro's new drug application for riboflavin ophthalmic solution for use in keratoconus and post-LASIK ectasia. This is not FDA approval by any means for their riboflavin, but the FDA does take this into account when making its final approval. There's been some challenges with the FDA with cross-linking, and so hopefully, I think we're all hopeful that within the next year it will be approved, if not sooner. The next step then is, once it's approved, for it to be covered by insurance, and so that can also be another year or two delay. So I was also asked to speak a little bit about cataract surgery in keratoconus and the post-corneal transplant patient. So I know Dr. Wei talked a little bit about this, and I don't think you're covering this in your talk, right, Dr. Farid? No. Okay. So this is very similar to conventional cataract surgery, but really there are a few considerations. It's the health of the cornea. If you've had a corneal transplant, you want to look at the back layer of cells of the cornea. There's a layer called the endothelium, which we haven't talked about much today. The endothelium is responsible for keeping the cornea compact and free from swelling. And in a graft, that's some of the most precious tissues you can have, because that tissue does not regenerate. Unlike the surface of the cell of the cornea, which continually turns over, the posterior aspect of the cornea, which is the endothelium, is fixed, and it just goes through a degenerative process with age and after a transplant as well. And so we want to make sure that that's okay. One of the most important things is the stability of the cornea. So many patients with contact lens wear, keratoconus, corneal transplants are in hard contact lenses. And the hard contact lens can give you great vision. But if you have a cataract, does everyone know what a cataract is, by the way? More or less? Okay. So even though your cornea, you may be getting good vision from your cornea, if that lens inside your eye is becoming more opaque, you want to try to be out of your contact lens, just say you're intolerant, you're having more trouble with dexterity, whatever the case may be. You want to make sure you get that cornea to its most natural shape. Soft contact lenses, can mold the cornea to a lesser degree than a hard contact lens, and we usually give a rough rule of thumb about 2 weeks out of a soft contact lens to make sure that the cornea is stable. With a hard contact lens, it can be variable. I've had patients, who've been in contact lenses for years. Sometimes they're stable within a month, sometimes they're stable within 6 months, but the only way to do that is to check and recheck and make sure that cornea is stable, and it has a lot of implications when it comes to cataract surgery, and mostly in regards to what's called astigmatism that Dr. Wade talked about. So regular versus irregular astigmatism. And also, when we look at the lens that we put in someone's eye, one of the most important factors that we look at is the shape of the cornea. It's the length of the eye and the shape of the cornea. Well, the length of the eye doesn't change much, but the shape of the cornea certainly can. And so we want to make sure that you're out of your contact lenses and you get a stable topography or tomography. The other thing is, if you have a corneal transplant, you most likely have sutures in place, and we want to get all those sutures out, because that can affect the shape of the cornea as well, which then can turn into an effect on our measurements, which we call biometry. So in patients with keratoconus post-corneal transplant, the biometry can be off for the factors that I mentioned. There's different types of IOLs that we can put in. So when we remove your cataract, we replace that with an intraocular lens. And 25 years ago, 30 years ago, when they did cataract surgery, people would come out with these big Coke bottle glasses. Well, now we've taken that big Coke bottle glass and put it into a lens inside the eye so that we can achieve good vision, sometimes without correction. And depending on your eye, there are monofocal lenses, which are the standard lenses, which may be your best bet if you're going to continue to wear a contact lens. A toric lens, if you have a fair amount of astigmatism that's regular in nature, a toric lens may be your best option. And then there's a newer lens that there's what's called a pseudo-accommodating lens, which is the crystal lens, which is supposed to move within the eye to give you distance and near vision. They've come out with a toric version of that, and there's still room to see if that's actually going to help patients with keratoconus or not. And then you have to balance in the fact that you still may need glasses or contact lenses post-operatively, and how that affects your decision making going forward.